So I will just finish in 2 slides that lurbinectedin and tarlatamab are great options that we never had before for small cell lung cancer after initial progression on chemoimmunotherapy. Lurbinectedin has efficacy, both progression-free survival and overall survival, not as dramatic, but it is there with an absolute median survival advantage of 2.6 months. Tarlatamab, more impressive responses over a year for some patients and CNS activity, which we had not seen in lurbinectedin. So tarlatamab will cause, for patients who can tolerate it, definitely a bigger impact in the second-line setting. There's toxicity to both of these regimens. For the lurbinectedin arm, we see more grade 3 and 4, mostly neutropenia, anemia, some nausea, some of the chemotherapy, fatigue, and myelosuppression. Tarlatamab has these 2 serious immune-related side effects, cytokine release syndrome and ICANS, which is a neurotoxicity for which patients have to be monitored and managed well. And who is the best candidate? So I think for both of these tragedies, patients who are finishing their induction and still doing well are the best candidates for this because of both of these treatments have side effects. I don't know if tarlatamab is really realistic for a very frail patient who's already has a lot of comorbidities and losing a lot of weight really fast. This requires a hospital admission and patients can be at risk for hypertension. So patients that already are having organ dysfunction are not the best candidates for this. There are other costs to this drug. So for lurbinectedin, it's an IV infusion that requires coming to the cancer center. Tarlatamab requires hospitalization at least the first 2 to 3 times for observation. And after that, a close monitoring in the clinic with significant shared time. So in summary, lurbinectedin and tarlatamab are powerful second-line maintenance therapies with unprecedented overall survival advantage in the second-line setting. However, toxicity and tolerability makes both therapies difficult for all patients. So we have to really select the right patients for these options, but definitely a brand new day and many good things to come. I think we need better patient selection to really find out which patients will do the best on these treatments, and also better prediction of side effects so that we can get more patients through these very life-changing second-line options. Thank you so much.